Hello everyone and welcome to this webinar. A very quick presentation before starting. I am Pierpaolo Lucchita, company owner. Like who follows our Globus Academy already knows, in the last 3 months, we have started a webinar program in order to try to bring out know-how. We do webinars on various topics, on the TCAR, on kineo, on TENS, on pains and so on. Today, we wanted to present a webinar a little bit special. I took advantage by Giovanni Carissa, a physiotherapist, as well as a friend, who works the Sant'Antonio Hospital, and that in the useful Tremitesi he devoted himself to dealing negativized patients. Today, we talk about COVID, a topic of great interest. I think it is something that interests you to many physiotherapists, and I believe it is very interesting to know. When the face is a patient who must be rehabilitated, and that obviously it was negativized, how it should be treated. So I would leave the word to Giovanni. Thank you for your attention. I invite you, if you have any questions, to write them, to do them. We will try to answer out to end or during the webinar. We will reply to all. For which thanks and good webinar. Now that we're gone, I can take off the mask. Good morning everyone. I am already was presented, therefore no delay beyond. I am a physiotherapist at the Sant'Antonio Hospital in Padua. We unfortunately had to deal with the outcomes of this pathology. And there is still the pandemic in progress. We will still see several people who unfortunately, despite having managed to survive the disease, they find several difficulties. Before the presentation, I would like to make a small introduction concerning the pathology. I'm obviously not here to teach nothing to anyone. I have tried as much as possible to synthesize what they are currently the knowledge present in the literature regarding COVID. Be aware that it is a virus and of consequence a pathology that still is therefore the object of study. Information we have is still partial. For this I will be a little generic, but above all keep in mind that this is definitely not meant to be one academic lesson. Indeed, he wants to be more a chat between colleagues. Therefore, I invite again to ask questions, and to confront us about it. If anyone has already had experience with patients of the genre is welcome, indeed his contribution in this regard. There will be one first very short theoretical part, in which will explain the pathology, the state of art, what we know so far based on the information, its effects from a point of view rehabilitation and physiotherapy. Obviously, we leave all the acute part to colleagues who work in the acute phase. I'll just give a few pointers on that which has been done in recent weeks. We will focus on negativized patients. What does it mean? The patient who survived infection, but which has a number of sequelae, which unfortunately they will go to inflict much on his abilities, motor skills and its respiratory performance. Let's see what it is state of the art. First of all, COVID is a pathology triggered by a virus, that unfortunately now, everyone they know it is SARS-CoV-2 virus, which is a viral strain belonging to the SARS-CoV virus. It can have a diameter between 50 and 200 nanometers. And that will be important to remember regarding the protections. The virus, as far as it is concerned, we know it persists within 1 meter square around affected patients. Of course, we know very well that when a patient is affected is right keep the isolation. So that however, we always advise against dealing a positive patient and to use official channels, that now everyone do you know regarding the social distancing in isolation of that particular patient. What it happens inside the body that it was infected. The most common symptoms, they are those of infectious disease respiratory, but in reality, it has been seen that eye symptoms can be the most disparate. Mostly they are fever, cough, dyspnea, arthralgia, diarrhea, pneumonia, and in the worst cases septic and eventual shock death from cytokine storm. That is unfortunately what is sadly causing all deaths, which have occurred in recent months and in the past few weeks. Currently, the reason why this cytokine storm takes place, the reason why the immune system is thus overstimulated by this virus, is still under study. Above all, it is not our goal therapeutic, as for the eventual transmission. These are things that surely, thanks to the news or to institutional channels, you already know, but it is always right to remember, coronaviruses are mainly transmitted via eye droplet, that is emitted respiratory droplets by an individual, when coughing its statute, but also simply speaking. Why it is necessary now use the bezels. Above all, it is need to sanitize or use skin protection systems, gloves, to avoid the transmission through the skin, also because the problem is that once that the virus has settled on our skin, if we don't sacrifice our hands touching the face, the virus can get inside of the upper respiratory canals, infect them by creating that whole series of symptoms and problems that we have seen. The diagnosis, it is mainly carried out via tampon, which these days you are trying as much as possible of spread to the whole population, compatibly with the limits set from the reagents, which as we know they are limited. Until you have a tampon, indeed even better until you have it, 2 negative swabs, the patient is considered potentially infected. These are all things we already know, such as is spread, mainly shots of cough, or droplets of saliva that are dispersed in the air via sneezing, or talking, and they can come directly on our respiratory tract superior, if we don't have a mask, or you can deposit them on surfaces, and subsequently settle within our street's respiratory, if we do not sanitize or protect the area. This is a patient CT scan in the acute phase of COVID, and as you can see, there is one ground glass opacity of the lobes posterior of both lungs. This is to show how much the cytokine storm we were talking about earlier, it can create structural damage in our patients. We can't wait to get to this state, and we must try as much as possible of prevent the spread of the disease through the protections, and above all we must avoid arriving as much as possible this stage trying all the maneuvers, either at the pharmacological level in therapy intensive, but also on a level physiotherapeutic. The protection, mainly on our street's upper respiratory, we can find templates that are segmented, as you can see, in 4 great chains: the surgical procedures, FFP1, FFP2 and FFP3. How can you read the big differences that the mask surgery and FFP1? Summing up a lot quickly, they serve to protect others, but not they protect ourselves. They can filter out particles that eventually we could spread via a sneeze or via a cough. But a potentially infected patient who makes a sneeze or a blow of coughing on us can potentially infect us. For this there are FFP2 and FFP3, both, as you can see. They may also have valves filtering. Valves are useful to the operator that not using filtering may have difficulty during the work shift. As much as you can imagine working 6 or 7 hours with one front mask can accumulate carbon dioxide in front of the nose and therefore, moreover, make the person tired. It can also cause level irritation of the skin. But the problem with those valves is that they do not actually create any filter for patients. So the best kind of protection would be an FFP2 or an FFP3, without valve, or an FFP2, with a surgical mask over or under. We must always and necessarily use this type of protection? It depends. For what concerns surgical mask, just and go, since hardly, unless let's talk about therapy treatments intensive, we will deal with patients that go to create droplets in proximity. The cases, in which it is better to use the FFP2 or FFP3, are in fact all of those treatments that can generate aerosols, as in expectoration. In some cases, as we will see later in the acute rehabilitation of COVID, or add example if we go to treat the temporomandibular joint. Moreover, based on the evidence present, we find that we must avoid to have fluff on our face, so you have to shave for avoid spacing with the mask. We must also try to cover the hair in case of maneuvers, with generation of aerosol. They can also be put on waterproof shoes, AI liquid, and washable instead of covers shoes, because it has been seen that unfortunately, the use of shoe bodies creates more chance of infection, as they take them out and put them on, could more easily spread the virus. It is obvious that if we talk about one physiotherapy office or center, or an area not hospital, is not necessary to use all these protection systems. It is only needed when you are at risk of droplets. So the classical physiotherapist with his office, he can safely use his bed, gloves and surgical mask. The most is done, obviously, however, the patient, in such a way as to avoid infect or be infected by a patient. Therefore it is necessary that the surface of the bed is washable and sanitizable, so you can destroy the virus itself may be present on surfaces. These are protection rules that by now you already know. Use gowns and visors, always in the case of droplets and in therapy intensive, but especially washing hands, with a wash of at least 60 seconds, cleaning all the ravines both of the back and the palms of the hands. Also we advise you to use the appropriate signage that Line's National Guide suggests us to affix in our studio, so that inform patients and children any accompanying persons. Use all maneuvers the rules you need for avoid the spread of coronavirus. Social distancing, ventilate the premises, use a waiting room, for example with chairs at a safe distance from each other. On the other hand, hand washing for the patient, etc. Cleaning can be done with disinfectant cleaners, and it is important that these have at least 70% of them of alcohol. In fact, it has been seen that this is the best type of disinfectant for this type of virus. Please, remember to clean not only one workstation, but all of them, the stations, like those information technology or all areas where the virus can nesting, such as desks, computers, coffee tables, etc. A very brief excursus on physiotherapy respiratory, in the intensive phase, that is what it is done by physiotherapists in the intensive care. First of all, the use of HFNO, as you can read, it is a particular mask, which serves for ventilation of the patient, and is affixed to the patient in such a way that he can increase oxygenation within the blood and improve the patient's saturation, but especially, try to also make up for great difficulty of the patient to breathe, as the virus any previous pathological state, for example heart disease, it actually weakens the capacity respiratory system of the patient. Also you can use the CPAP, which as you know is ventilation with positive pressure, however not should be used throughout the duration of intensive care, but at the most an hour, in order to stimulate the patient as much as possible to use ion accessory respiratory muscles and not airway clearance techniques. These can be always interesting in an intensive care setting, but they can also be exercises that to be assigned to the patient to do at home to avoid sequelae at the respiratory level.
propri muscoli respiratori, accessori e le sequele a livello respiratorio. Faccio un esempio.
I give an example.
Una tecnica di clearance
A clearance technique, which is often taught, consists of placing a hand in front of the patient and ask to breathe while pretending that the hand is a glass to be misted with the breath. The patient must feel the breath on the palm of your hand. This technique is a breathing of forced type, with open glottis, because the biggest mistake that often executed is to close the glottis, such as in the maneuver of Valsalva, in which the patient throws out the air by closing the diaphragm and then making the palates open. This, unfortunately, we have seen that it is not very useful in all respiratory diseases. With unproductive cough, as in the case of COVID, which mainly creates cough type dry. This breathing creates an increase in relaxation alveolar, and therefore in fact to improvement of saturation. Another type of technique are the maneuvers of recruitment. What does it mean? They are maneuvers in which it is always done forced breathing like that than before, but the patient is asked to stop the exhalation and breath phase. Hand in front of the patient, I inhale. This is always to stimulate openness of the alveoli. This maneuver must be always done with the glottis open. Obviously, all these maneuvers, they are done in intensive care. They simply serve to give you an idea of which were the treatments performed in hospitals by fellow physiotherapists in intensive care. In addition to this, there is also the possible aspiration endotracheal in intubated patients, where simply they take away any secretions present. It was not widespread, because as I have already said, the COVID does not create many secretions. Usually sputum, it is not particularly present. Finally, pronation, last but not least. Patients were placed in the prone position to increase saturation. This makes you understand how important it is the use of certain postures, immobility in patients suffering from respiratory diseases. We will also see this later in the treatments. After this very quick excursus, now let's see what we can do physiotherapists in the patient population who was hit and survived. We assume that they are not guidelines. The pandemic still is in progress, so we don't have the yet chance to tell if it is a scientifically proven thing. Obviously, the basis on which we use these treatments is a solid foundation. We transfer our knowledge in the field electromedical level of the population affected by COVID, before to see what kind of treatments do. We must also understand what their symptomatology will be of patients who have been suffering from SARS-CoV-2, and understand what the sequelae. First of all, you have to take into account that the treatment must be done on the healed patient. I want to be very clear about this. The patient has some symptoms that can manifest an active infection in progress. Let them be the hospital, e-health authorities to treat it according to the guidelines. Such as, do you know if a patient is cured or not? We currently know it is from consider himself cured a patient who has at least 2 negative swabs and that does not show signs and symptoms. It is not always possible to have a patient who has performed tampons. We know that. For this we must use protections for us and for the patient. Measure temperature as a parameter objective to understand. if eventually there is an ongoing infection. Need also take one thing into account. The treatment physiotherapy creates a problem that is interpersonal distance, the famous social distancing that now the government rightly dictates, as in commercial activities, but even in everyday life, it is impossible to implement in the scope physiotherapy, and that's why it is necessary to use the device's individual protection. The treatment in itself it is not impossible to carry out. Now the current provisions say we are authorized to carry out a treatment. It is obvious, however, that the devices are used. If not used, you know that you are performing an illegal act. The pandemic is still ongoing, as we have said, so currently it is still difficult to understand what the sequelae of this pathology. We have the first data, fortunately, because there has been a lot of effort from part of the researchers to be able to collect all epidemiological data, and it has been seen that this pathology creates preponderant sequelae, obviously a respiratory level. The first are disease polyneuropathy critical, called critical illness, which is actually a syndrome present in all patients who have had a stay medium or long in intensive care regardless of infection. In the which is in fact weakness, and asthenia generalized. In fact it is one problem caused from prolonged bed rest of the patient. We will then have a defunct patient, a patient who will have lost a lot of mass muscular, and that he will definitely have one loss of ROM, of the range of movement. We must also keep I realize that patients who pass in intensive care, statistically speaking, they are the patients older, so hardly let's talk about young people who have faster recovery. Another very widespread following is the critical illness myopathy, which is a syndrome similar to the previous, where in fact in addition to a generalized sarcopenia, there is also an asthenia and a difficulty of movement, any given adipose degeneration, muscle atrophy. What else can we find? Mainly we can find comorbidities, which increased the probability of patient himself to enter therapy intensive, such as tumors and heart disease. They are also often present kidney damage, electrolyte disturbances, coagulation disorders. Furthermore, it has been seen that a good percentage, 36.4%, develop neurological symptoms, migraine, disorders of consciousness, convulsion. This is still under study, of course. It is not yet known if the virus manages to attack the nervous system, as at example the herpes virus, but often neurological syndromes, especially in the nervous system peripheral, are associated and is important to remember for our study level treatment. Less frequent, but still considering the high number of people who have been infected may be present other bed rest syndromes such as adhesive capsulitis, pressure ulcers, entrapment neuropathies. Finally, obviously it's not about our scope, but it is still important from consider, the population that unfortunately she was hit by this pathology may have accused a psychological and cognitive level a number of syndromes, from which hardly will be able to recover in no time. We are talking about an event global pandemic that was unmatched for decades. So the patient will definitely be afraid. It will be a patient who can also be demoralized. Consider that often a situation like that also current at the socio-economic level, it can affect the patient. So try as much as possible also to establish a relationship of trust with patient you treat. Why, obviously it will be a patient who will have difficulty getting out, literally out of the house, and to show up in the center or in our studio. So consider these issues. What are the goals that we physiotherapists we must ask for the treatment in our patient? We have patients who have been subjected to prolonged immobilization. Therefore, what should we do? We have to mainly improve their motor skills, improve any given joint limitations from prolonged immobility, and we must increase as much as possible motor performance. We thought about which ones there could be the types of treatments used with electromedicals to treat these problems, and we have come to conclusion that currently, with all the evidence that we have in hand, the types of treatments to use are mainly three: TCAR, magnetotherapy, and electrostimulation. Yes, based on scientific works behind it, the development of these technologies, we've thought about what they might be the practical indications in the use of these tools. It is obvious that electrotherapy does not replace as normal therapy or exercise therapy. The latter is a lot important for patient recovery, but it can be important advantage for reach as soon as possible our goal. As for the TCAR, I'm talking to colleagues so we know more or less what we're talking about. However, let's make a quick excursus. We're talking about a condenser that uses electromagnetic frequencies ranging from 400 to 1200 kHz. What does it mean? This is an electromedical device that has the function of creating an electromagnetic stimulation of the tissues, superficial or deep, depending on the type of treatment, capacitive or resistive. This is due to the fact that with TCAR we have the possibility, by varying the parameters, to focus this stimulation more on the surface or more in depth. The TCAR up to now has almost always been used for musculoskeletal purposes. Periarthritis, tendinitis, muscle tears, etc. However, as we'll see shortly, they're the first studies, carried out before the pandemic, about the use even outside of this scope. Meanwhile, let's see the difference between capacitive and resistive. As you can see in this graph, the green line is given by the increase in temperature created by the capacitive, the blue line by the resistive, with the same power. As you can see, the treatment via resistive electrode not only increases significantly the temperature compared to the capacitive, but keeps it for longer. This happens because, remember, the difference between capacitive and resistive is that the resistive is able for his electronic conformation to stimulate on a deeper level as compared to the capacitive, and we know that the big vessels, that the large lymph node stations and in general all our internal organs are located deep inside. If we are able to heat this area by 1 degree, this area keeps the heat for longer as compared to a more superficial area, and this will be important to consider in the treatment with TCAR therapy. This was also highlighted by scientific studies I'll show you quickly to make you understand that TCAR does not only mean using a machine that heats. Many people say, so I can simply use a hot water bottle to heat a patient. The problem is that the hot water bottle, as shown by this study, fails to increase the hemoglobin saturation as TCAR does. These are the different depths in centimeters, and there is also difference of 5%, which in terms of saturation is a lot. So we have a reference in evidence as far as the increase in blood saturation is concerned by using TCAR. We also have evidence that TCAR increases vasodilation and the permeability of capillaries. Specifically, this work was done on a tendon. However, just like in the musculoskeletal system where tendon vascularity is quite poor, we have the same effect as on any other tissue. It is obvious that vasodilation depends on the type of tissue, but if we are able to increase the capillary permeability at the level of the tendon, imagine at the level of the parenchyma or in general at the muscular level. Also, I would like to make it clear that this is a completely different therapy from classic old physical therapies that are still widespread, because I understand that hurting the patient, conceptually, is not the oldest treatment in the world. You could decide to use the Marconi therapy, radiotherapy or all other therapies where you may have infrared, as in this case from an antenna. The problem is that the radiation that impacts on the patient is largely reflected, which is not the case in TCAR. In this study we can see how high-power TCAR and low-power TCAR increase a lot, as compared to the other therapy, the volume and the intensity of the blood flow, and this was seen through electron microscopy. Finally, one of the studies that were published has shown that high-powered TCAR on thoracic treatments in patients who were not affected by COVID, because obviously this American study was done earlier, increased mobility at their axillary level, at the level of the xiphoid and of the 10th costs. All these articles that have been published in peer-reviewed journals can then be supplied by us at the end of the presentation for those who want. As we can see, there is an increase of the displacement with respect to the 10th rib. In some cases of 4 centimeters compared to 0, when obviously you don't have a treatment. You can easily understand that increasing the thoracic mobility increases the patient's ability to decrease the reduction of the ROM and above all to improve the technical skills. Taking all of this into consideration, now let's try to treat one of our patients. We have talked about a treatment at the thoracic level. Obviously, in order to improve his mobility skills, we will see the difference before and after, and above all I will do a simulation of treatment to show how you physiotherapists' colleagues should work to treat patients. Before the patient enters, remember that we must protect ourselves, so we sanitize the hands, in this case with alcohol gel. Remember to clean the whole hand area. Back, knuckles, thumbs and also the distal side of the forearm. With the hands clean, let's go and use our gloves that will be disposable for each patient. Remember that. Now the mask. I am using a FFP2. Although, as I have already said before, if I do not perform maneuvers that generate aerosols, I can simply use a surgical mask. Now I'm ready for the treatment. I asked my patient to get closer. The patient in question has already been equipped with mask and gloves. I check the temperature to be sure there is no high temperature. As you can see, we are well below 37.5, that is the degrees indicated by the WHO as possible sign of infection. Treatment with TCAR. Our focus now is to improve the mobility of the patient. Let's do a little test. I tried to ask the patient to stand with his arms crossed above the chest and rotate to one side and the other as long as he can. Let's do it again with open hands like this, rotating in one direction and the other. We will have a rotation of about 90 degrees. Then we measure the patient's ability to flex and extend the trunk. Can you please stand up, turned in that direction, towards the wall. Let's lean forward as if we has to touch the toes as far as we can. Let's go back, hands on the hips and fold back in this way. Then we will see the difference between before and after the treatment. Can you take off your shirt, please? First we sit down. As you can see with Diakari 7000 we have the possibility of using different treatment parameters that may vary from patient to patient. Obviously this is not a course about the treatment with DCAR, that is not the goal of this course. But remember that what I am giving to you is just a general indication, and therefore from patient to patient it may vary depending on age, body size and outcomes. Basically, however, we must remember the parameters that are essential for a treatment of this type. We have to treat in depth at least initially to reduce the inflammation. By selecting the program we will have to use the resistive mode and a low frequency, so that we can go deep. Here we have saved a specific program, COVID-19 consequences resistive, so as to remind you the most important things. Depth, so resistive treatment. Now I kindly ask the patient to lay on his back. The plaque is placed at the thoracic level facing towards the resistive electrode that will be put in contralateral position. We place it exactly in the center on the chest, so that we can also stimulate the effect on the bronchi. As you can see, I am using the resistive electrode, the one with longer diameter, so as to cover a larger area. Remember that for thoracic problems the ability to increase sternal and thoracic mobility is important, and it is an area that is also very important in terms of size. Therefore, since we have got the chance to use a machine like Diakari 7000 that delivers energy largely sufficient for this treatment, we also take advantage of electrodes that have a long diameter in such a way as to have effect on an area that is as large as possible. We increase the power. As you can see with Diakari 7000 I have there possibility to change not only the frequency and the type of electrode, as you have seen before, but I can also see how much the patient is absorbing. In this case, 33-36 watts, of course I'm moving. So it also depends on the area of the treatment. I ask the patient if he feels heat. Of course it takes a couple of minutes before creating a heat that can be perceived by the patient, because we are working in depth and the receptors in depth are not as numerous as on the skin. In any case, the patient must be questioned about the possible sensation of heat only to avoid situations in which a patient feels too hot or discomfort. Remember that the only objective parameter remains always and in any case the energy absorbed, that, as you can also see from the histograms, is high. The histograms in red indicate important energy absorption. And for this reason I have lowered a little bit, and now I ask the patient for confirmation. You have to trust the sensitivity of the patient. If necessary, tell me if it bothers you. These histograms are important to understand the treatment we are doing, because they make us understand in real time the response of our patient's body to the energy that we are delivering. There are other parameters that can be viewed. At the bottom right we have the resistance of the patient in ohms and also the energy delivered.
Qui abbiamo la resistenza del paziente in ohm e anche l'energia derivativa.
Remember this resistance because in the capacitive treatment you will see the difference with the same power of these two parameters. I'm only using 22% of the machine power and I'm not even using the boost mode, which is one particular mode, so you see that there is not a real need to use a lot of energy, but just always check that the type of treatment is comfortable, while making the patient feel an energy between 20 and 35 watts maximum, which is a medium-high power similar to that used in the previous study. Obviously we are going to treat both sides of the thoracic cavity, the right side and the left side. The device was previously cleaned and sanitized. Remember to perform this sanctification before and also after the treatment. Now to get back on time I'll pause the treatment and show you the difference with the capacitive mode. Same treatment geometry. Same power, in this case 22% of power, and as you can see the patient's resistance is extremely higher than before. We are between the 700 and 800 ohms. So you understand how actually the type of treatment it is much more superficial. Probably also the patient feels heat differently. After it will probably be a more superficial sensation. Is it useful to use this type of treatment? It depends. The capacitive is more useful to treat muscle masses, for example the pectoral, also stretching, in such a way as to decrease the contracture that is often present both at the level of the large and the small pectoral and at the level of the sternocleids. Obviously I'm talking about people who have been intubated or bedridden for a long time. Another muscle that is often affected is the inspiratory accessory muscle of the serratus anterior, which is located here. Again we make a capacitive treatment to stimulate the muscle mass which is more superficial than the ribs, the pleura, etc. Alternatively it is possible to carry out a treatment in lateral decubitus. We have the patient sit up. Remember that the return plate must always be as much as possible contralateral to the patient. So if we want to stimulate the right side, in this case, we will place it on the left side. Let's raise the arm and stretch out in lateral decubitus. Let's put our right hand here behind the head. Let's go back to resistive mode, and also here as you can see with similar parameters the response of the body is similar both in terms of resistance to the passage of current and in terms of power absorbed. We are always between 25 and 35. That is our guideline for treatment. This position also partly drains the possible secretions. Please don't forget that aerosol stimulation, it is not indicated when you are not doing intensive therapy and especially when you are not using suitable protective equipment. Therefore this type of treatment helps the patient to increase above all the ROM. Finally, I also recommend you to treat in the prone position to improve lung capacity with a resistive treatment of the electrode resting on the paraspinally muscles and the thoracic vertebrae. Can I interrupt you? There are several questions and congratulations from home to you. There's a question about the thrombotic consequences that have occurred. What are the treatment possibilities of TCAR? Is it possible to use it for that treatment? What to do in these cases? Regarding the thrombotic outcomes, TCAR improves the vascular permeability of the affected area. Remember that one of the main contraindications of thrombosis, although it depends on the type, is the mobilization, therefore you can absolutely do it. Just remember to get in touch and work in a team with a vascular surgeon or with whoever performed ultrasound or diagnosis to avoid maneuvers that may in some way cause problems such as thrombus mobilization. Another question from Marta Lucrezia Bonetti. In case of home treatments and therefore without the possibility of using the TCAR or other professional electromedical devices, how can we act? Any suggestions? It depends. We have thought of a treatment that is mainly respiratory, but you may also find a patient who from the point of view of breathing is perfect, but who is defied or who has had entrapment. On the upper quadrant, it depends on who's the patient in front of you. The most important thing is that you protect yourself and your patients. There are no forbidden maneuvers except for those that are against common sense or the sense of our profession. I would mainly focus on motor rehabilitation with exercises that improve the tone and trophism, especially of upper limbs, because those who do respiratory know that patients need to be stimulated in the recovery of their respiratory capacity, and possibly all those maneuvers at the cervicodorsal level which are used to unlock or to regenerate, to improve the ROM of the cervicodorsal column. Let's move on to the last two treatments, last but not least. Now that the patient is gone, I can take off my PPE. Remember to take off the gloves this way, so avoid the surface that you have touched you come into contact with others. Like this, then the gel. They also ask us if we have portable treatment products, home care or equipment not for study. Absolutely yes. We have the 5000, which is one TCAR portable, which of course it is a less powerful version of the 7.000 for needs portability, but that in many areas, including this one, can give excellent results. Results as it only needs to a few more minutes of treatment compared to the 7000. It is placed in a suitcase very small like briefcase, weighs little and you can safely use. Other than that, I reconnect. What we were saying before, there are some types of treatments don't only TCAR but with others electromedical, in particular magnetotherapy, electrostimulation are treatments. We already know why they are very old treatments. Any hospital or in general any clinic now has these treatments, but old does not mean old or obsolete. This is because, as mentioned before, we have focused on technologies that were used especially in the field musculoskeletal outside the scope classic. We know magnetotherapy, everyone, but here too we do a very quick review. These are pulsed magnetic fields in which one has the formation of a magnetic field and by induction creates an electric field in the body. This means that a treatment level of the patient's body is mobilized of all the molecules present within the body itself. They will come aligned in the generated magnetic field from magnetotherapy. This happens at certain frequencies and at certain powers, and that's why we can't For example, consider mobile phones as magnetotherapy, and it is the same reason why not we can't even consider magnets a magnetotherapy. Because they are static fields. Frequencies generally go from 0 to 100 Hz and the intensity from 0.5 to 100 Gauss. We know very well what it is the effect of magnetotherapy on the bones. It has been used for decades to consolidate fractures that have never consolidated, or in general to speed up the process of ossification. This is because the magnetic field generated by magnetotherapy creates an electric field within the tissue bone, which is piezoelectric, or is a material that, thanks to the field electric, deforms, stimulating the production of new material. This happens in the bones as in many other tissues. In the bone is more evident, as between our fabrics is much more like a crystal in terms of composition of the material. But we can, for example, find this type of interaction even within a range. Also, we can see it even within the vascular tissue. If in the classic bone treatment we use high intensities or high frequencies, between 70 and the 100 Hz, we can also transfer this type of vascular effect. I don't know if you've ever heard of so-called streaming potential. Electric potentials created by the charges present within metabolites which pass inside the blood vessels, and that therefore, being electrically charged, by definition they create a current. Metabolites such as iron present in hemoglobin, calcium, sodium, potassium, etc. Imagine this flow, which is a real current. Since we are talking about blood vessels and capillaries, obviously we cannot use high intensities, since these could not edit these fields, which are obviously very weak. Therefore, if we use an intensity low, here I marked 1 Gauss, but you can even up to 10, or anyway low frequencies, we can stimulate neo-angiogenic growth. This can be seen from several studies that they have been made, and this is one of the reasons why only now is it known that magnetotherapy also has an anti-inflammatory effect, as it stimulates neo-angiogenesis and vascularization. As you can see, this is one study that was done on proliferation and on the tubulization of endothelial cells, which are those used in the training of vases. Here you can see the difference between controls and magnetotherapy in terms of the production of these cells endothelial. They also come, for example, used, as can be seen from this study, also as fields that stimulate the growth of the endothelial factor vascular, always used inside of neo-angiogenesis, and see how it exists here too, a huge difference between control and the treatment in the production of these vascularization factors. Finally, another effect is a real separation of the red blood cells by electrostatic force. Normal blood and blood treated with magnetotherapy for a few minutes. As you can see, the alignment of the magnetic field created a true separation of red blood cells, which in turn they actually managed to move more easily within blood vessels. Contraindication of magnetotherapy. This also applies for TCAR, those with pacemakers or any other implanted electrostimulator in the patient's body. Contraindication prudential, that is, you can only use it if authorized by the specialist, in this case by the oncologist. In the case of oncological pathologies, because if for example we have a tumor, a melanoma in the head area of the patient, we can very easily treating an ankle. But obviously it is right, talk to your trusted specialist. The same is true in general. For the patient's intolerance to electromagnetic stimulation, this varies patient to patient and it is altogether subjective. For what concern treatment with magnetotherapy, here we have the Magnum 3500, which is a magnetotherapy that can be used with different types of solenoids. I recommend use of coarse solenoids or applicators of big dimensions, always for the same principle we have seen before. The interesting thing is certainly more important with regard to magnetotherapy is that it can be used on patients with much more ease compared to TCAR. For answer the question that was me placed first, even magnetotherapy can be used at home. Also, there is no need the patient undress. I have already set up a treatment like before, low intensity and low frequency. We support the solenoid at the thoracic level and we wait. Generally a treatment ranges from 20 to 30 minutes. The patient will hear a small tingling, so as to feel that the vascularity is reactivating, but it is subjective, so it depends. It may even be that he feels nothing. This is not to say that the magneto does not, it works. Keep in mind that 7 to 8 applications are required to get the effects that we have seen. Finally, I would like to dedicate one very small parenthesis to electrostimulation. Because how do you have seen before, among the problems that have arisen in patients who have survived the COVID, there are many problems of the nervous system peripheral. Often they are present neuropraxia, or others motor deficits, psychics in a certain region, anatomical, level brachial, lumbar, etc. In that case, I recommend you use an electrostimulator such as, for example, the Genesi 1500, which gives the possibility to modify them all parameters within it depending on the type of electrostimulation that we want to carry out. This is because, ad example, stimulate a muscle level tonic or phasic changes a lot depending on our target. I can choose between electrostimulation, for example tenso microcurrent, so interferential, or ad example as in this case denovated. If we have electromyography available, so much the better. However, when we go to pick a certain type of correct, we can choose the number of phases, the duration of the phase, the type of stimulation, continuous or intermittent. We can also choose the type of modulation, whether in amplitude or frequency. The working frequency, amplitude, start of work and microseconds, also at the end of the work, and the duration of the single pulse. Obviously that's not the goal of this course, is to teach you how to use all these parameters, and possibly it could be argument for further information for any other seminars that we can organize if you want. It is obvious that these technologies give the chance to have one different stimulation. That is for the tone and trophism, whether for pain, in the case of interference at example, or that it is simply for stimulate and the eventual innervated trunk. In a very useful way for the patient defied or who has this type of problem. A question that others have posed: there are contraindications to the use of electrotherapy? For example, in muscle recovery in sarcopenia in the patient with COVID result. Contraindications are the same of magnetotherapy. So if there are any pacemaker, or others in general electrostimulators implanted inside of the body. Because obviously we don't want to interfere. Here too they are prudent oncological pathologies, and of course all normal precautions in any one electrostimulation. So if the patient has hirsutism important, you have to shave. Use disposable electrodes for each patient, do not use them on different patients just to avoid cross-infections. Mainly these are the contraindications. Thanks John for this excellent presentation. Remember that inside of the globuscorporation.com/academy site, there are many other training contents. I remember that at the conclusion of the webinar, there are some questions to which you can, if you please, answer to improve our service. To other questions we will reply in next hours, because we have already breached our time. So thank you for being with us. I hope I have given my good ideas colleagues and also not. We are here for hear your opinions. However, share them and above all to seek the more possible to help out also in these cases to get up our patients. Thank you very much John. Goodbye. Visit the Globus Corporation Academy section. You will find many courses and training videos always at your disposal.